Okay, well, why don't we go ahead and get started? Okay, well, good afternoon. My name is Tom Giovadetti. I'm the president of the Institute for Policy Innovation, a 34-year-old free market think tank based in Dallas, Texas. I'd like to welcome you all to our Zoom briefing today on the topic of how wokeness is infecting the medical profession. Thank you all very much for joining us today. We appreciate you being with us, and I want to especially appreciate those who chose to make a donation when they were registering for the event. We very much appreciate your support. Your support is what makes it possible for us to do everything we do, including events like this. And if after this event you'd like to know more about becoming a supporter or member of IPI, you can contact Addie Crimmins, and she will be more than happy to chat with you about that. This is our second Zoom event with Tevi Troy. So if you enjoyed this one, you should check out the previous one that we did with Tevi. It's on our website again, and it's on our YouTube channel. It's on his book. It was last April, and it's on his book, Fight House, Rivalries in the White House from Truman to Trump. That was a great event. Tevi is a true Renaissance man. He's an expert in more than one field. He's a historian of the presidency, but he's also an expert on healthcare policy. And because today's topic is related to healthcare, that's why we're going to rely on IPI's resident scholar, Dr. Merrill Matthews, who's our resident healthcare expert, to moderate the discussion in the Q&A with Tevi. Today's topic is driven by an article that Tevi wrote for Commentary Magazine for their November 2021 issue entitled Wokeness MD. And by the way, Addie and I, at least, are big fans of Commentary Magazine and the Commentary Podcast, so we highly recommend that to you. And some of you in the Dallas area may remember an event that we did 3 years ago with Noah Rothman, who's also part of Commentary Magazine and part of the Commentary Magazine podcast. So you might want to check that out. And now on to our topic. We're all aware of how woke culture has turned many college campuses from havens of intellectual diversity to virtual re-education camps for what we used to call political correctness. And you're probably aware of how wokeness is working its way into major corporations and large employers. The really noteworthy thing about Tevi's recent article for Commentary is about how woke culture is starting to affect the delivery of healthcare services. Can you imagine a world where the quality of healthcare you receive or the level of healthcare you receive might be affected by your level of wokeness? Tevi, this morning I had a doctor's appointment at 8:20 this morning. And I was struck in preparation for that appointment by the battery of questions that I was asked about my personal financial situation, food security, whether I had missed any meals in the last 12 months, job security, stress and anxiety, and all of those things. I've never been asked those things before in preparation for a doctor's appointment. They call them social indicators of health. And it's a little bit unsettling to me because it seems to me like it's the thin end of the wedge. It seems to me like sort of like a harbinger of the wokeification and politicization of healthcare. And so we're really happy to have you here today to talk with us about this emerging issue. I mentioned earlier that our resident scholar, Dr. Merrill Matthews, will be moderating the Q&A, and our Director of Development and Events, Addie Crimmins, who, by the way, Tevi, is the unofficial Texas president of the Tevi Troy fan club, will also have some comments and questions for you, I'm sure. And again, as I said, we'll try to get to as many audience questions as possible. So with that, I'll turn it over to Dr. Merrill Matthews to sort of formally introduce Tevi, and then we'll get on with the program. Thank you.
Well, thank you, Tom. And Tevi, I think this is such an important issue because any fair assessment of the history of U.S. healthcare would say there has been disparities in healthcare in the past. And the primary thing that people point is the Tuskegee experiment, in which the Public Health Service allowed, I can't remember, a number of Black males to go for something like 40 years from the 1930s to the 1970s, tracking them with syphilis and not treating them to see the long-term effects of syphilis in males. And it was only sort of exposed by, I think it was the Washington Star paper at the time. And when it did that, public sentiment sort of turned that around. But we have had disparities. We still have some. Back when we started doing the vaccines here in Dallas, there were concerns, as we had big areas where people were going, that minority populations were not being reached as much. And it wasn't because there was anything they were trying to do to prevent that. They were trying to figure out how to reach the minority populations to get them in higher levels of representation. So there are issues in the past, but we're moving to something completely different. And with that, I'm going to just turn it over to you.
Well, thank you very much, Dr. Matthews. And before I begin talking about my article, I just want to say some nice words about IPI. The reason I did the first Zoom a couple of months ago on my book, Fight House, was because I had tweeted something about tech policy. I know Tom says I'm a Renaissance man. I'm not really an expert on tech policy. And am I good now? Yeah. So I had tweeted something about tech policy. Renaissance man, but Tom is a real expert on tech policy. And he tweeted, his response to it, and that led to a conversation, a very civil conversation, even though we had a slight disagreement on the particular issue, in which Tom and I started. I think we'd met once before years ago, but we kind of rekindled our friendship and put him on my mailing list, and he came up with this idea of having the Zoom talk, and I've really appreciated that we've been able to do that, and I really like all the good stuff that IPI does. I also appreciate getting to meet Addie, who I know is a huge member of the Tevi Troy fan club, and we're happy to have you. And then Dr. Matthews' stuff on healthcare, I've been reading and appreciating and learning from for many years. So thanks to IPI, and thanks to all of you who are participating in this event, listening to this event, and supporting IPI, because it's a really terrific organization. Now, in terms of the article I wrote, which I wrote for the November commentary, which has quite an arresting cover, and we might be able to put it up on screen to show everybody. It's all black with just 3 words in red saying woke: the threat. And it has other articles from David Zucker, who did the Airplane movie, where he talks about wokeness in comedy. He actually has a great line in there. He says, people come up to him all the time and they say, oh, it would be impossible to do Airplane today, given the kind of humor you have. And Zucker always has the same response. He says, no, it'd be easy to do Airplane today. We just have to do it without the jokes, which I think really encapsulates what's going on in Hollywood and in the humor realm today in terms of wokeness. There's a great piece by Barry Weiss about courage and how to respond. It looks like Eddie's a fan of the Barry Weiss fan club too. But Barry Weiss has a terrific piece about the need for courage in terms of how to respond to this woke threat. And then there's my article on woke healthcare. And look, I know conservatives are worked up about wokeness. I am worked up about wokeness. But one thing I don't like is just a bunch of hand-wringing. People say, oh my gosh, this is terrible. Western civilization's coming to an end. Let's bury our heads in the sand. What I try and do with my articles, and I've written about this issue a couple of different times. I've also written about wokeness on college campuses and the whole cancel culture and the threats to free speech. What I try and do is I look at the issue in a sober way, analyze where it's a problem, and try and come up with some solutions. So that's what I want to do today. Talk about the 3 areas I examine in my article, talk about how I suggest we push back, and then also talk a little bit about the reaction to my article. And I've gotten a lot of feedback from the article. So first, when John Podhoretz, who was the editor of commentary and a terrific guy and a real warrior for conservative causes and against this wokeness stuff, he approached me and asked me to write a piece on wokeness in healthcare. And I didn't just want to write that hand-wringing piece about, oh my gosh, woe is me, the world's terrible, don't go to your doctor anymore. What I wanted to do was examine if there's this phenomenon of wokeness, where it would be appearing, and to what extent it is appearing in the key areas of medicine. And what I identified are 3 main areas. Number 1 is it affecting the way doctors provide treatment to patients? Because I think that's really essential. That's at the essence of what we want from our doctor. We want our doctor to treat us fairly. What Dr. Matthews described in the Tuskegee experiment is horrific. We're not treating people's illness because of their race and the desire to get some kind of research out of it is just abhorrent, and it goes against everything we believe in modern Western medicine. So not treating people fairly because of their race, whether today In the past, it was because of being people of color, and today because of not being people of color. That is not where we are or where we should be in terms of medicine. That's the thing I want to examine. The second question is it affecting research in terms of the essence of research is the ability to use the scientific method, to ask serious questions, to have doubts about issues and ideas, to have disagreements, and to come up with what the right answers are, not based on politics, but based on facts and reason and logic and what the actual medical scientific determinations are of various experiments. And then the third thing, and this is also really important, is training, because what's going to happen to the next generation of doctors? Tom went to the doctor this morning. I'm sure his doctor was trained in the great appropriate way, which is it's a difficult pathway to become an MD, and they go through a sort of boot camp in terms of going with very little sleep and having to memorize all kinds of stuff. And it's almost like I don't want to insult anyone who's a Navy SEAL, but kind of Navy SEAL, but for doctors, right? I mean, it's a very, very intensive training period. And if we are going to take a woke lens and say, well, we're not going to put people through this very difficult, challenging training period because we want to meet certain woke goals, as opposed to getting the best doctors, then that's a problem, also, and a problem for the next generation. So I'm sure that Tom's doctor this morning went through this ringer, went through this boot camp, and was trained in the appropriate way. But are we going to be training the next generation in the appropriate way? So those are the three questions I looked at and tried to get at. Now, as to the first question, of are we treating patients unequally? And in this case, in these days, what we're talking about is treating people who are not on the, what we call the intersectional scale, treating those people worse. Now, what's the intersectional scale? This whole theory that the more, I guess, indicia of past discrimination you have, the better off you are, the higher you rank. So indicia of intersectionality could be homosexuality, or being a person of color, or being differently abled, or being a woman. So the more of those you have, the higher you are on the scale, and the fewer you have of those, the lower you are on the scale. So at the bottom of this scale of intersectionality would be, sorry to say it, Meryl, I'm in the same camp too, but just a plain old white male. Right, so those people are in the lowest end of the intersectionality scale. Tom, you also fit. And so those people, according to a theory of wokeness, would be treated less well in a variety of different ways, including in the dispensation of medical care. Now, I don't believe that this is widely happening, but I am seeing indications that the woke people, the woke mob, would want to have this happen. And what are some of the indications? So one was, I talk about Brigham and Women's Hospital in Boston, which is one of the best hospitals in America. There are these two woke women who wrote a paper suggesting treating people basically based on their intersectional characteristics. So meaning people with fewer intersectional characteristics would be treated worse than other patients who were treated after them. They would be lower ranked. And again, this is important. One of the core tenets of Western medicine is to treat everybody, regardless of who they are, the same. And we see this after a terrorist attack or a mass shooting, that the victims and the killer are treated the same by the doctor. The doctor doesn't look and say, oh, this person should get treated worse because they did something bad or because they're from a not preferred race or group. That is just important. And I actually tell a story from a movie that I kind of liked it from a couple of years ago, Death Wish, not the original Death Wish with Charles Bronson, but the remake with Bruce Willis. In this movie, Bruce Willis plays a doctor. And in the very first scene, and the first scene is where you establish the character of the person. Bruce Willis is this surgeon who has to try and save the life of a Chicago cop who's been shot by a perpetrator. And he fails to do it. The guy, the wounds were so bad, he can't save the police officer. But then the next person is rolled into the operating room, and that person is the shooter. And the Chicago cop, who is the partner of the dead police officer, says, and now you're going to save the animal that killed him. And Bruce Willis says, if I can, and goes to do his job as a doctor and try and save that person's life, because it's not his job to determine the merits of the patients. It's his job to fix the patients, to heal the patients. And again, that is a core tenet of Western medicine. We see this in American medicine. In Israel, there's a kind of famous ethic where if there is a terrorist attack, you treat the terrorists just like you treat the victims. Even though we might find the terrorist important, that is just how we do it. And you shouldn't treat people differently based on their race, their skin color, their intersectional characteristics, or what have you. So this proposal at Boston Brigham and Women's Hospital was rejected. So that's a good thing. But it's not like the women who suggested it were rebuked in any way. And in fact, one of the women went on to become a senior health official in the New York Public Health Department. So it's not like people are shunning this woman for having, I think, a very bad approach, but she's actually getting elevated in the field of public health. So I think that's worrisome. Then there also, and this has been on Barry Weiss's indispensable blog, Katie Herzog has been talking to doctors, and they have, and again, this is anecdotal, but she has instances of doctors saying that they're hearing when a white person comes into the hospital, they're saying we should treat them last. Now, again, anecdotal, not evidence, not data yet, but indications of a worrisome trend. So I would say that right now, Tom, you go to your doctor, you can feel safe that you're going to be treated fairly and equally. But if we allow this wokeness to persist, if we allow these ideas to proliferate throughout medicine, and we don't push back, then we could be in this bad and uncomfortable place that, again, is abhorrent to the concept of Western medicine. The second, and this gets to the idea of why some of these stories that Katie Herzog has told are anonymous, is the question of whether you can have free and open discussion and debate within the medical profession. And this gets to the question of how you do scientific research, how you do medical research, how you come up with new cures, how you identify what works and what doesn't. With the coronavirus thing we're dealing with, initially, people would come to the hospital, they'd be put on these ventilators, and the ventilators weren't working. The death rate for people put on ventilators was something like 87% in the early days. And then it was discovered that instead of putting people on ventilators, you put people in the prone position, you lie them flat on their stomachs in a certain way, that you are getting better results. And that was based on experimentation. We saw what was working in the hospitals, we saw what wasn't working in the hospitals. We didn't say, we'll cover this up because it's problematic politically. We said, this is good scientific information, let's spread that information. And so I tell the story of a cardiologist in Pittsburgh, who's an MD, who wrote a paper about the idea of affirmative action in medicine. And he found that it was not providing benefits in terms of getting better doctors and better healthcare. And this was a peer-reviewed paper, and I guess it made it through the publishing law initially, but then the woke mob saw it, and there was a massive overreaction, I would argue, and this person's paper had to be retracted. Now, the doctor, Dr. Norman Wang, is suing his hospital, University of Pittsburgh Medical Center, and so he's pushing back on it. But this idea that you can't do a peer-reviewed, data-driven study if it's politically not correct or it doesn't conform to what the woke mob wants is really problematic and really worrisome to this whole concept of what medicine is and how to get to the best medical results. And my friend Jonathan Rausch wrote a great book this summer about this whole concept of wokeness. And in the book, he talked about how Western medicine developed. And again, through the scientific method, through being willing to question things that have gone before us, not to make scientific determinations based on politics. And if you make those determinations based on politics, you're not going to get good scientific answers. So again, I'm not saying that all science is bunk at this point. I'm saying there are some worrisome trends in the medical field that make me wonder about the ability to produce better cures, better innovations, better medical and health improvements in the future. And if we allow wokeness to proliferate, we will not come up with the best medical solutions in the future. The third area, and I touched on this already, is the area of training. We all know what doctors have to go through in terms of the hours they have to stay awake as a resident and the prodigious amounts of information they have to memorize. And it's only the top students who even make it into medical school to begin with. And then even there, the most favored professions or the best professions within medicine, the best specialties only go to the top people. And that is based on merit, and it should be based on merit. And what we're hearing now in this new era is indications that there are doctors who are afraid to rebuke residents for being late, or students for being late. Or some of the medical schools are pushing back against the very notion of grades because it may not conform to their woke ideology. Now, I have a nephew who is a newly minted MD, and he's to the left of where I am, but he and I had a long talk before this piece came out, and he says that what I attribute to wokeness may also be a different phenomenon, but also worrisome. This whole everybody gets a trophy approach of American life today, that the participation award kind of stuff, that we just don't want to be as tough on people in general. It may not be wokeness, but I do think there's a woke component to it in terms of trying to reach certain demographic goals and not looking at merit, but looking at intersectional characteristics and trying to build a class that looks a certain way, or build a profession that looks a certain way. So I think there's a combination of both. I take his point, but I think that that wokeness is proliferating here as well. And again, if we have a sense that you're not getting the best doctors because their ideology is trumping their willingness to practice medicine in a fair and even-handed and scientific way, then Tom's going to be a lot more nervous or wary about going to the doctor at 8:20 this morning, or maybe he's going to be just more selective about what kind of doctor he goes to. Maybe he'll look and see if the doctor is tweeting woke stuff on his Twitter feed and say, I don't want to go to that kind of doctor. I want to go to a doctor who kind of looks things in a neutral way, that assesses me just from my patient needs and not based on my intersectional characteristics or lack thereof. So those are the three things I try and look at in the piece. Those are the three questions I answer. And in each one of them, I'm saying, don't panic, but there are reasons to be worried and a need, this is important, a need to push back. And in terms of pushing back, again, I don't want to be a hand-wringing conservative and say, woe is me. What I want to say is we should identify things that are universally abhorrent in Western medicine, right? This idea of not treating people equally, and use that as the ground on which to fight and push back and highlight what it means if we go in this woke direction. We won't have better, faster cures in the future. We won't have the top trained doctors in the future. And we won't have people who feel like they can go to the doctor and get a fair shake. And so I think those are strong grounds on which to stand. There's that great book, The Killer Angels, about the Battle of Gettysburg, where at the very beginning, one of the Union generals goes and stands on a hill overlooking the area, and he says, this is good ground on which to fight. He was looking for good ground. And I think this is good ground on which to fight. And that's what I try and identify in the piece. Now, I know I'm almost out of time, Tom, and I know you want to open up to questions, but the last thing I want to mention is the reaction to my piece. I haven't gotten any negative pushback. People haven't said, oh my gosh, we totally disagree with you. But what I have gotten is from doctors and people in the medical profession who say, it might even be worse than you say, and giving me additional stories and examples of really problematic trends. One doctor who I know is a very good ER doc and a friend of mine, he said, that was a terrific piece. This is why I want to quit medicine. And I said, no, that's the exact wrong approach. This is why you have to stay and fight. And he told me that there is a push in the hospital to allow all kinds of gender transition surgeries. And he asked some questions about, well, is there any indication that these gender transition surgeries for minors are beneficial or reduce suicides or reduce mental distress? And they said, don't talk about that. This is our policy. And so, that's worrisome. There's also some people have said, this is subsequent. I couldn't have included this in the piece because it's subsequent to when I wrote the piece, but the AMA put out this new kind of language guide that tells you how you can talk about things. And you can't talk about people having conditions based on being low income, but you have to talk about they're being disadvantaged because of the structural elements of society that have led them to be disadvantaged. So it comes up with a sort of Orwellian way of speaking about people's conditions instead of just directly saying, okay, this person is poor in a poor household, you might have less good nutrition or something like that. And so the AMA Orwellian Speak Guide is something that came out subsequent to my article, but is also something that is worrisome. So I think my reaction to the piece is, I think I've touched a nerve. I think it's worth fighting on this, and I think there's even more ammunition than I even found in the initial draft of the piece. And with that, I'd be happy to stop and take any questions you guys may have.
That's really fascinating, Tevi. Thank you so much. It's interesting when you write a piece and you find out that you maybe were even too conservative, right? in your analysis. I want to turn things over to Merrill Matthews. I do have a couple questions, but I'm going to defer to Merrill and Addie, and then if there's time, I have a couple questions. But let me turn things over to Dr. Merrill Matthews.
Thank you, and thank you, Tevi. And I'll ask a couple of points. Number one has to do with the research that you mentioned and the belief in science, which conservatives are being accused of not believing in science anymore. And for 10 years, I was on the University of Texas Southwestern Medical Center's Institutional Review Board for Human Experimentation. For those who don't know, that's when you're doing research protocols at the medical school, it has to go through a committee. That's what I was on. And over those 10 years, I think we probably did 2 or 3 research protocols on sickle cell anemia. And as I recall, all of we were going to go out and look for African Americans to do that research on. But I think you even mentioned this in your piece. If you're going to say there's no genetic differences out there, would we have had to say, well, we can't ask the questions of your genetic background. We're going to take anybody who applies, even though we know sickle cell anemia doesn't affect an awful lot of populations. It seems like it would just be a bizarre research study to do something like that. And the second thing I'll mention is, just from the wokeness standpoint, we occasionally did research protocols on breast cancer, the genes in breast cancer, especially the BRCA gene, I believe it is. And if you had a male who was identifying as a female and said, I want to be part of that protocol, males can get breast cancer, but it's not common. I just wonder if the medical schools would have to go in that direction if they're embracing these things.
Yeah, well, first of all, let me just say, and I appreciate these good questions. Medical schools don't have to go in these directions. That's my whole point. I saw your caveat, if they're embracing these things. Yes, if they embrace these foolish things, then they go in those directions. But they don't have to. They can fight, we can fight, and we have to push back. This whole idea of conservatives being against science really irks me. It seems to me that if science suggests one thing and conservatives object, then conservatives are anti-science. But if science suggests something else that goes contrary to what the liberals believe, then, well, that's just good policy. So it really seems like it's a one-way ratchet, that only when conservatives have an issue with some scientific judgment, then it's a blanket declaration that conservatives are against science. Well, there's all kinds of ways, and we've talked about them already in this talk, where liberals don't want to look at the science, and that is either ignored or certainly not as an element of liberalism. So I completely agree with you on that. And let me just say that having a scientific method, being able to assess things in a rational, logical way, is not only the only way to move forward in terms of medicine, but it's the reason that we don't do bloodletting anymore. It's the reason why we've made advances in medicine, why we have antibiotics and all kinds of things that are materially improving and extending the lives of millions of people around the world on a daily basis. It's the scientific method that gets us there. And if we reject that for putting political lens on everything, we as a society will be worse off.
So my second question goes to having to do with the identity politics that's involved in this at a time when the country is becoming more of a melting pot. I mean, we're getting more interracial marriages and stuff are expanding exponentially out there, and it's increasingly becoming hard to determine exactly what a person is. I mean, my wife's sister, who's from Iowa, married a Bolivian, so their family was Gutierrez. They've had kids. The kids are 1/4, I guess, Hispanic. If you want to say Hispanic is a Bolivian, but they're, for all intents and purposes, they appear to be part of the white culture, and that's happening within the Black community and other things. I'm just wondering how if you're trying to push in this direction, the population is making it more and more difficult to do that.
Yeah, look, as you guys know, I'm Jewish. I don't know when I woke up and suddenly became white. I mean, that would have been news to my ancestors who were told, no Jews or Italians need apply. And so, the way in which they torture themselves and twist themselves into knots to define white as people they don't like and not white as people they do like is really insane. I mean, even where there were some suggestions that the percentage of Hispanics who voted Republican in this last election was up, and there were suggestions that those Hispanics who vote Republican should be considered white, but other Hispanics are not. I mean, it's truly insane. And then you've got the issue of Asians, who by definition are Asian and not white, but they're considered white because they seem to do well at school. So it really makes no sense. And we are much better off trying to get to Martin Luther King's vision of a colorblind society. The sooner, the better. I think this is an unfortunate detour on a path that we were headed towards. And remember, I believe it was Sandra Day O'Connor who said that we've got these affirmative action preferences. They should go away in 25 years as we become this colorblind society. We're close to the 25-year mark. This, again, is an unfortunate detour from the direction in which we were heading and should be heading, but it's worth noting some of the inherent contradictions of the approach, as you did, Dr. Matthews, to make sure that we show the absurdity of some of these concepts.
I'm going to turn it over to Addie.
I have 19 questions, Tevi, but one of the biggest things that struck me from your talk was the research piece. And I know Dr. Matthews touched on this with much higher knowledge than I have, but I think part of the piece of just communicating with people who aren't as familiar with healthcare terms or anything like that, how important that is and how it affects everything sort of downstream, not just with COVID, but with everything, and how the steps the medical society takes to just enforce research, I think, is a big deal that I don't think is given enough credit, if that makes sense.
No, it makes perfect sense. And one of the items I talked about in the article is there was a study that was somewhat shoddy, but it appeared to show that that African-American babies get worse results than white babies. And it was pretty quickly debunked from a scientific perspective, but there was a sense that you're not allowed to talk about the debunking of this study because it was politically favorable to discuss the study. So the study got all kinds of positive attention when it easily could have been shown that it was not necessarily accurate study. So if studies that have a politically favorable result are highlighted, but studies that are politically unfavorable are not highlighted, then then you're not really going to get to the answer. And I think we saw this a little bit with the COVID stuff this last summer, when if Trump mentioned a medication, it seemed like the entire public health establishment was trying to debunk whether that medication would work or not, regardless of whether it was an effective medication. I personally don't think hydroxychloroquine is a good response to COVID, but it seems like there are some circumstances where it could be warranted. Or remdesivir is Trump mentioned it, and it seems like it's an early first generation antiviral. It's not perfect, but it's not. It didn't necessarily require the loathing and vitriol that it was receiving from the public health establishment. And I think we just got to look at these things from their scientific merits and on their medical usefulness, as opposed to trying to say, well, somebody I don't like on the wrong side of the political spectrum has touted this, so we must debunk it. I think we saw this a little bit with the vaccine. I'm sorry, I just one more. So you saw Kamala Harris talking about how she would never be in favor of the vaccine that's coming out of the Trump administration. And then suddenly the Biden administration is not only pro-vaccine, but pro-vaccine mandates, which I could just imagine if Trump said we're going to do mandates of this vaccine. And again, I am pro-vaccine. I think people should get the vaccine. I've gotten it. I'm boosted. But to say that politically I don't like the guy who's in charge, so I'm anti-vaccine. But then now I do like the guy who's in charge, so I do like the vaccine. That is the exact opposite of the scientific method, and that is what we've got to avoid.
Well, and I think there's a sort of, and I've learned this, I'm the luckiest person in the world to work with Buddy just peripherally, just to bend his ear sometimes, but I feel like the process between research and the end result is so it's complicated, but it's also people don't learn about it, and so the research piece is huge, I think, and I'm glad you mentioned it. I think there's so much that goes into saying we recommend this for you, or we want you to do this, and that's been a big takeaway for me. So
I'm glad you mentioned that, because look, I think research is so important, but it's also, like I was saying earlier with the Gettysburg analogy, is that is good ground on which to stand. Americans like the fact that we developed that vaccine in 10 months, which is just unheard of and couldn't have been done, say, 20 years ago. Americans like the fact that we have cures for a whole variety of disease, or treatments for a whole variety of disease, and things that didn't exist 100 years ago. The ability to get better after coming up with a malady is so much more readily available today than it was 10 years ago, 20 years, 100 years ago. And the only way to get there is through non-political, nonpartisan, scientifically vetted research. And I am all for research, and I think we've got to keep research protected from this woke stuff as best as we can. And it's good ground because the American people, they like their therapies, they like this idea that America is an innovation leader, and they want to keep that. And this whole idea that America is the land where I guess the plurality of scientific innovations, of new drugs, new molecules that are identified, the plurality, if not the majority of them, come from American and American companies. And that's something the American people like, and they don't want to give that up so easily just for some woke slogans. So I'm getting all worked up here, but I feel strong.
No. We want you worked up. We want that. We don't want our audience going to sleep. I'm going to sort of use my moderator's prerogative to ask you a couple questions. Addie and Merrill have both focused on this research part, and that's the part that most concerns me as well. So I want to further drill down on that, but I want to back out maybe like 30,000 feet. I have had the great privilege for more than a decade of being associated with Merrill Matthews. And one thing I have learned from him is that the direction of medical research over the last couple of decades has been toward what he refers to as personalized medicine. And it's a recognition of the fact that different genetic profiles, they matter a great deal. And certain drugs are appropriate for people with certain genetic profiles, and they're not appropriate for people with other genetic profiles. And that we're getting to the point where we are going to have customized medications for people based on their specific genetic profile. And without going into any personal details, I know from my own family, we've had some genetic work done. And we know what we have, what we carry, what we have a propensity for, et cetera, et cetera. It strikes me that the greatest poison of this wokeness is this idea of viewing everyone by racial and sexual class, and it cuts directly 180 degrees away from personalized medicine. So when I walk into a doctor's office, the question is not, what is Tom's genetic profile? How will this particular medication operate according to his individual genetic situation? Whereas, in a wokeness culture, I walk into the office and they say, he's an old white guy, and it just strikes me that if where all the technology is going is toward highly personalized, individualized medicine, but where all the sociology is going is toward viewing everybody as simply part of a class or part of a group, that there's an enormous conflict there. And it's going to affect the quality of healthcare that is delivered to people. Because the way we continue to deliver better healthcare to people is to treat people as individuals rather than participants in a group or in a class. So could you comment on that?
Yeah, it's a great point, Tom. And let me just first say very clearly that I'm always on the side of technology over sociology. So there's no doubt on that front. Look, when I was Deputy Secretary of HHS about 12 years ago, personalized medicine was the thing. People were talking about it all the time. I think, and I'd love to get Dr. Merrill's take on. I think we've been hearing a little less about personalized medicine in recent years, even though there's so much promise in it. And like you were saying, let's say you have you hear. Well, let me go about it this way. You hear that a vaccine is 60% effective or 90% effective, or different vaccines are different effectiveness level. What if by looking at someone's genetic code, you could determine which therapy would be 100% effective for that person? Or even, let's give it a little margin of error, 98% effective. I mean, that would be so much better than giving people a therapy that, works 60% of the time or 68% of the time. And that is the promise of personalized medicine. And that is kind of where we are headed. And that is what data and science and computing power can all bring us to potentially in the future. But if we are going to be talking about this woke stuff and everybody's just in a generic category based on their intersectional characteristics, that is the exact opposite of personalized medicine. And it won't allow us to get to the place that was promised a few years ago that could be hugely potentially beneficial to all of human society. To just if you can identify medicines that work for the specific individual, it's just so much cheaper, it's so much easier, it's so much more effective, you get better results. And the people get the medicines that they need. So again, I'm a big fan of personalized medicine. I do feel like we've heard a little bit about it less in recent years, but I think there's still a lot of potential there and a lot of promise there. And I hope wokeness doesn't get in the way of it. And I'm speaking out on this issue because I want to not just hope is not a strategy, but I want to be part of the effort to push back against it.
So wokeness really cuts against this idea of personalized medicine. But, if we sort of back up one level of hierarchy, we do know that there are certain conditions that tend to affect racial, ethnic, and sexual groups, right? We know that Ashkenazi Jews, for instance, have particular health genetic issues, right? We know that there are, we know that, for instance, women have different symptoms from heart attacks than men have. We know that there are sexual differences. We know there are genetic differences. We know that African Americans have a higher propensity of heart problems. We know that, for instance, sickle cell anemia is concentrated in the African American population. And so if somehow wokeness prevents us from even identifying people, if wokeness prevents us from saying this patient, is black, or this patient is a male, or this patient is an Ashkenazi Jew, or whatever, at the very least, you're cutting against medical efficiency. If I'm a doctor and I know you're an Ashkenazi Jew, I can immediately start thinking about particular genetic profiles and things. But if I'm prohibited from even knowing that, and we're getting to this point of like remote medicine where it may be that the radiologist or the person who's looking at the test results never saw the patient, right? So if you don't put on the paper their racial and sexual status, they don't know. And it strikes me that wokeness is going to add friction to the process rather than efficiency and better results. It's going to add friction and it's going to add delays to the process. If you're no longer allowed to identify people by their racial or ethnic or their sexual orientation, sometimes those are shortcuts that actually help, Dr. House actually figure out what's actually wrong.
Yeah, I think, Tom, I agree with you, but I think it may be even more pernicious than you say, because wokeness is not as consistent as you say. There's inherent contradiction. So it might be that they'll say, well, we favor African Americans, so sickle cell is a genetic disease that there's predisposition in the African American community. Let's study that. But Ashkenazi Jews, as you said, have a propensity to get a Tay-Sachs, which is another genetic disease, but they're white. So let's not study them as Jews because we can't look at them in that way. So wokeness looks at racial characteristics when it wants to, but then blurs racial distinctions when it doesn't want to. And again, I think that's not scientific. It's contrary to what you're talking about in terms of personalized medicine, and also isn't going to get us to where we need to be in terms of the cures and therapies of the future.
It also it also brings up this issue of how so much of medical research dollars are politically driven. There was a statistic a few years ago that like the federal government devotes 10 times more money to breast cancer research than to prostate cancer research, right? And you have one that tends to occur in the female population, and you have one that tends to occur in the male population, but just because of political reasons, one is elevated over the other. And
We
I
weep
also
for you, Tom. We weep for you.
okay,
Really.
thank you so much. Thank you so much. And you also make this point that it's not so much male or female differences, but you have this issue of genetic differences like Ashkenazi Jews and Tay-Sachs disease or whatever. If you can't, sometimes identifying what group or class someone is a member of is actually a shortcut toward diagnosis, or it's at least important diagnostic information. And if you're purposely blinding the diagnostician to that information, you're slowing things down, you're creating friction and causing problems.
Yeah, look, it's many different ways of getting to the same problem, which is by not looking at science and not looking at research and allowing politics to get in the way, you're not going to get to the places where you need to be in terms of developing the therapies and the cures of the future. And again, focusing on how we can turn this back. The American people like the fact that America is an innovation nation. They like the fact that we lead the world in therapies. And if this holds us back, if it makes it harder for us to develop personalized medicine or other new types of therapies or new cutting edge vaccines, look at mRNA. It's just a groundbreaking type of vaccine, exciting stuff. That not only has health implications, it also has economic implications, right? America, one of the economic engines of America has been the fact that it develops new innovations, new technologies, and constantly does that. And if we can't do that because politics gets in the way, then we are going to suffer both from a health perspective and an economic perspective.
Okay, so we have a number of questions from our audience, so let me try to get to a few of those. We have a couple of questions that are related to this idea of acceptance into medical school, and I think you mentioned that, and I think that's a really important point. There are certain professions that I really want to be merit-based. You know what I mean? If I'm having brain surgery, I want the surgeon who's operating on me to have been, the top of his class. He or she. I don't want him or her to have gotten through medical school because of some sort of wokeness or something like that. I want to know that they have the merit and they achieve that result. So we have a couple questions on this issue of diversity, inclusion, and equity related to student acceptance into medical school. You touched on it. How big of a problem is that right now, or is that just a problem you're anticipating?
Well, the Norman Wang paper suggests that it's a problem, that they're spending a lot of resources on trying to promote certain genders or ethnicities or races in medicine, but that it's not necessarily leading to better results. But if you can't study it, and if you do study it, like Dr. Wang found, you're going to have your article pulled and your own status pulled at the university, then we're not going to be able to ask these questions. So, and I think it's a disservice to doctors of all races and genders who might have their credentials questioned because they are from a group that gets certain preferences, even if those doctors didn't get preferences to get there. And so I think what we want to do is we want to make sure that the American people know that all medical selections are merit-based, and to the extent that they are merit-based, and people will have more faith in their physicians and be willing to take their advice. Because if you go to a doctor and you don't trust their advice, that also has implications for healthcare. I mean, there's a whole area in medicine where you talk about whether it's called adherence, where you talk about whether people actually do what the doctors tell them to do, whether they take the medications that the doctors tell them to take. If you don't trust your doctor for political reasons, again, whether it's because the doctor is spouting off politically or because the doctor may have taken another path to medical school, then that's going to have an impact on adherence. So even just in this conversation, the more we talk about it, the implications in other areas in terms of not just faith in the medical system, but in terms of health and in innovation and economic predominance, all these things could potentially be negatively impacted by wokeness and woke medicine. but also all these things are areas that we can seize on in the effort to push back against trying to put wokeness in our medicine. I talk in the article about a book that I happen to love by John Silber, who is the president of Boston College. And he talked about the architecture of the absurd. What he said is that in all kinds of art, you can do absurd or abstract art. The art doesn't necessarily have to work if you're putting something on a canvas. But when you're building a building, the architecture has to work. Otherwise, the building falls down or it collapses or doesn't keep the cold out or doesn't keep the heat out, or it just doesn't do what it's supposed to do. And medicine, I liken to that, because you can't just be guessing stuff in medicine. You can't just be putting your political preferences in there in medicine. Medicine, it's kind of a binary question. Are you helping the patient or are you harming the patient? And if you put this woke lens on things, then you're entering this area of not architecture of the absurd, but medicine of the absurd. Are we not focused on what it takes to heal the patient, but on what we want to hear politically in order to conform to our woke ideology? And it's really worrisome if we go in that direction.
Or what basically takes the patient to you? I mean, we know so much about mortality among African American women, right? Among pregnant women. If we tell them that they should not trust certain doctors, it's sort of a chicken or egg effect, maybe. I mean, is that if you're sort of perpetuating this idea that there are doctors that will believe you or doctors that won't, and you're a population that is of certain risk, how do we rectify that? How do we know who chooses what doctor? And there could be well-meaning doctors that understand all the risks that an African American woman would face. I mean,
yeah, it raises an that a friend of mine who was looking into the Build Back Better bill, saying is how that what it's trying to do is wokeify medicine, meaning it looks at certain outcomes and says that they are based on structural racism rather than, let's say, behavioral choices. So if you have, let's say, worse, higher infant mortality, and that happens to be based on higher incidence of drug use, for example, but that is attributed to structural racism as opposed to the individual activities, the individual behaviors that led to it, then that is a real problem and doesn't let us get at the answers we need to try and address these issues. So I said to my friend, oh, that's a really good idea. You should write a Wall Street Journal piece on highlighting all this. He said, oh, no, I couldn't do that. It might hurt my ability to get existing clients or to get business, or I don't want to be canceled. So, I mean, it really is pervasive to the point where we can't even talk about this stuff, and it gets really worrisome.
Well, Tevi, that actually raises a question. We have in the woke culture and education, increasingly, especially in public schools, some places where they say the African Americans need to be set apart in a separate class away from the whites so that they are learning things differently from the whites. And I wonder if would we move to a time where someone would say, you're African American, you need to go to an African American doctor rather than any doctor, or you're a female, you need to go to a female doctor rather than a male doctor, because that's what you are.
I mean, that whole idea about the separate classrooms is just, I mean, it just, it hurts my soul, because, I mean, isn't that what Brown versus Board of Education was about? And this whole idea that we should integrate classrooms, that we shouldn't separate people by race. And
right, and it's just one small step from that to saying you should go to the doctor who is of your race and of your gender and so forth. I just wonder if that's where we're going with this.
Look, I hope not. I mean, you want to go to the doctor who works best for you, regardless of their race and regardless of their gender. And I just think, again, we're getting to the not just the architecture of the absurd, but the medicine of the absurd. If we're not going to base things on scientific reality, basing them on merit, basing them on what works, what leads to the best results for the patient, and what leads to the best cures for the future.
The common denominator, I think, in both Addie and Merrill's questions is this idea of distrust. And it seems to me that the medical profession and the healthcare profession sort of has a higher burden of trust and integrity maybe than other professions for this very reason. because we already have a high level of distrust out there. We have a high, we know from vaccine skepticism, for instance, that there's a high level of distrust. We know that certain racial groups have lower vaccination rates because of distrust. And so, you don't want people to die or to suffer maladies simply because of distrust. So it strikes me that, if anything, the healthcare profession has a higher burden of integrity and reliance on science than maybe other professions. And so there's something particularly nefarious, I think, about wokeness infecting the medical profession and the healthcare profession as opposed to other professions, just because of the importance of equality of access to healthcare.
Well, and the stakes are higher, right? I mean,
Right.
Just by virtue of it being healthcare, your
Right.
well-being, I mean, the
Yeah.
stakes are higher.
Yeah, the state of your heart health is more important than the state of whether or not your driveway has cracks in it or not.
Right.
Yeah.
Yeah, look, this trust issue that you raise is a really good and important one. And I touch on it in the piece, although I haven't talked about it yet. I mean, if politics start to infect medicine and also public health pronouncements, then it makes people less likely to listen to both doctors and public health pronouncements. And the best example I have of this is in the early days of COVID, there was this lockdown approach of nobody should go and mill about and people shouldn't get together in large groups. And the people who protested lockdowns in Michigan were killing other people by getting together. But then after the George Floyd incident, suddenly you have thousands of people in the streets, and the public health community, 1,000 medical professionals or public health professionals signed this letter saying that, of course, you should go out in the streets and protest even with COVID because racism is a more important issue. And it just struck me as this was based solely on political beliefs and not in any way on science. Why are some get-togethers or protests accepted and others not? You can't put a political lens on this stuff. If it is dangerous to get together in large crowds, as they were saying it was, and I think it was before the vaccines, then it's dangerous to get together in large crowds, regardless of whether it's for a good reason or so-called good reason or not a good reason. And the more that kind of stuff happens, the more the American people get skeptical of the public health community. And there's a friend of mine named Harold Pollack, who's a public health expert at University of Chicago. He's a very liberal guy. And he's written smart, cogent pieces for Politico and the Washington Post talking about how the public health community has lost its ability to talk to conservatives because everything they do is through the lens of politics. And he talks about the dangers of that, because if the public health community can't talk to conservatives, who are a plurality of the country, almost a plurality of the country, meaning a big chunk of the country, then how are you going to get them to do X when the time comes, when you need them to get a vaccine or to shelter in place or to wear masks or to do whatever it is that the public health community may deem it necessary for the people to do at a certain time? If there's no trust, and it's because people are putting their politics, public health people are putting their politics over and above their scientific and medical judgments, then you're not going to be able to get what you need when you need it in terms of a public health response.
Yeah, I kind of think we'll be studying the response to COVID for the next 20 or 30 years. And, I think one thing that historians will recognize is that the public health community did not cover itself in glory during this time. We have a couple of questions from our attendees related to the media's coverage of COVID and public health, and about how sort of the media didn't necessarily give us honest medical information, but also just parroted whatever they were getting from the CDC or whatever. It's a great irony that we have this situation where we've never had more access to different forms of information than we have today. But yet there still does seem to be this tendency to just sort of line up behind, whatever the government is saying about healthcare and, masks and vaccines and things like that. Could you comment a little bit about sort of the reaction of the media and whether or not the media has covered itself in glory or not?
Well, I think it's pretty simple. And can be summarized quickly. The media has not covered itself in glory. Look, the media has really revealed itself in the last few years. I mean, there's always been an issue of liberal bias. That's not new. But what we're seeing these days is blatant media rooting for a certain team. There's a great piece in the Daily Beast this week about Politico Playbook, which is something I read every day, and it's this great tip sheet on what's going on. And it says there's an internal war at Politico Playbook between the people who want it to be just a straight up political tip sheet telling you what's happening that day, and they want it to be the other side of this war wants it to be a player in its effort to push woke ideas and woke ideology. And it's really nefarious. I mean, one of the things they talk about is how one of the people who's on the woke side of this little war, they call them the woke police, is a big fan of Kamala Harris and doesn't want articles that question whether she's doing a good job in there. And, as we all know, she got approval rating somewhere around 28%. She does not appear to be doing a great job. She doesn't have great political skills. And you just wonder if the gatekeepers are saying, well, I don't want any stories that are out there that question my team. It's a real problem. I mean, Lord knows when the other administration was in charge, whatever story could question what they were doing would appear. And, that's the media's right. That's what they're supposed to do. But if you get the sense that they're going to filter it to keep out articles that might harm their team, well, then you're not really reading the news anymore. Then you're reading state propaganda.
Well, and sort of Tevi, Politico Playbook is supposed to be the anti-anything. It's supposed to be the anti-you wake up and you have the New York Times Daily, the NPR up first kind of thing. It's supposed to be, this is who is at war, and also in a very sexy way, like this is who is at dinner, and this is who got married, and this is the birthday. And Politico is kind of loathed by my friends at Pod Save America, which is the most liberal. And so it really, to your point, it really should just be an observation piece. I mean, it shouldn't be like stay in your corner kind of thing, right?
Look, I'm a big fan of Politico, or have been a big fan of Politico. I've subscribed to the newsletters for years. I've written for them many times. And they had a brilliant insight when they came into being 15 years ago. And, again, God love them, they just had $1 billion sale. So, I mean, they started with nothing and they built this up. But their brilliant insight was, we are not going to have an editorial page. You're not going to read the editorials, what we, the great Politico readers, editors think. The New York Times is an editorial page. Obviously, it's getting further and further left. The Wall Street Journal has an editorial page with a very specific voice, and you're going to get a conservative perspective. Politico said, we're not going to do that. There is no editorials coming out of Politico, because we are going to give you the news. And the reason your friends at Pod Save America hate Politico, when for the most part conservatives don't hate Politico. They just say, okay, conservatives, we get negative news from Politico, but they also give us negative news on Democrats. Because the media is supposed to be, I don't know if it's supposed to, but what they see their role is to give us negative stories.
Really
but you're supposed to give us negative stories on both sides of the aisle. And again, if they're filtering it, then it makes it a less valuable resource to all of us.
Yeah.
I didn't know we were going to go there, but it is something. I'm also worked up on.
Tevi, we have a couple of questions about ivermectin and hydroxychloroquine, and they're not scientific questions, they're political questions. And I think the point is how quickly those things got politicized. It's like because Donald Trump expressed some positivity about them, if you were anti-Trump, you immediately felt like you had to be negative. And it's like the whole thing became politicized before science even got a word in edgewise. And it may be that's the greatest example of some of the things we're talking about the politicization of medicine, is that, where were the medical voices? Where were the epidemiological voices talking about those things? It's like they were squeezed out. They never had an opportunity to speak. It simply became a purely political issue, whether you were for Trump or not Trump. And that determined, literally, your political orientation determined your choice of treatment for a pandemic, which is bizarre.
My thought on hydroxychloroquine was, boy, I hoped it worked. Not because Trump was touting it, but because it was the early days of the pandemic and we had no therapies for COVID-19. We had no vaccine and we had no antiviral. And I said, if this is going to work, that would be great. If remdesivir works, that would be great. You got to root for the therapies to work as opposed to saying, well, Trump wants them, so let's root against it. But now some Republicans question vaccine mandates, so let's root for the vaccine and not against it. But if Trump put out the vaccine and he was still president, we'd root against the vaccine. It's crazy to link your political beliefs to whether a therapy works or not.
Yep. And I think our last topic will be, we have a couple of questions about state medical boards and how powerful they are, how influential they are, and whether or not part of the problem here is state medical boards becoming captured by wokeness. And then, if you want to be certified, if you don't want to be disciplined, essentially you have to bow to whatever standards are set by your state medical board. I think a lot of folks in our audience may not realize how influential state medical boards are. I mean, they can discipline doctors in a state. A lot of the regulations related to licensing of healthcare providers are done at the state level rather than at the federal level. So, if wokeness
a lot of influence in legislative pursuits.
Right, exactly. Lobbying.
Yeah.
Right. So, to what degree
that denigrates it, I think, but
exactly.
A lot of influences happen that way.
Yeah. So to what degree have these state medical boards been captured by wokeness?
Yeah, it's a good question. State medical boards are indeed very powerful. I don't want to speak too definitively on this because we have 50 different state medical boards and I can't speak to each one of them. But I think the reason I'm writing on the subject, and the reason I'm speaking out on the subject, is so that they don't get captured, so that we can have a rational argument and a rational discussion where we say, look, here are the implications if you guys get captured by wokeness. You're not going to have doctors who treat patients equally. You're not going to get the best results from scientific trials, and you're not going to get new therapies, and you're not going to get the best next generation of new doctors. So I can't tell you a score of 37 state medical boards are okay and 13 are not. But what I can tell you is this kind of ammunition can help in the fight to make sure that state medical boards stay on the right side of things.
And let me just add on that, because we haven't mentioned the American Medical Association. It seems to, I don't know if I'd say be captured, but it certainly seems to be leaning towards the wokeness itself. And the interesting thing is, I haven't seen the figures for a while, but at least in the past, a relatively small percentage of doctors, something like 19-20% of doctors, were actually members of the AMA. And most of them were members of their specialty of what they were, but not a lot of them were members of the AMA. And I think a large percentage of those who were medical students. And the point being there is that if the AMA comes out and says something, it sounds like that's the medical profession's position on things, when the AMA actually doesn't represent an awful lot of doctors.
Yeah, Dr. Matthews, I totally agree with you there. It is a relatively small percentage. The AMA has been headed in a problematic direction. And in fact, in the article, I tell a story about a podcast. So this is a podcast that the AMA puts out in which a doctor says, well, doctors are not racist. They treat patients equally. And this was seized on by the woke mob as a terrible and important thing to say. And so the person who said it had to resign, but the head of the division within the AMA that puts out the podcast, who wasn't on the podcast, who didn't hear the podcast in advance, who had nothing to do with the actual production of the podcast, he was forced to resign as well because of this overreaction to a fairly innocuous comment saying that doctors treat people equally. So I think the AMA is going in a worrisome direction. I also mentioned their Orwellian language document that just came out recently, subsequent to when my piece was written. And I think, we should be concerned about the AMA, but we should take some comfort in knowing that it's by far not a majority of doctors and still a small minority of doctors. And if people hear about this stuff and say, you know what, I'm not going to join the AMA, that could be all to the good. Maybe you can get them to change their tune.
Tevi, go ahead.
I'll jump in.
Go ahead.
Tevi, if there's anything you haven't said already, what would you leave us with? I mean, in terms of action items or just food for thought?
Yeah, so let me just repeat the overall message, which is wokeness is bad. Wokeness is a problem. But we can't just bury our heads in the sand and say, oh, woe is me, we're all going woke and everything's going to collapse. We have the right arguments. We have good ground to stand on. I think the American people are largely in favor in favor of our positions. And I think in the last two elections, both 20 and 21, I think you could see both of them as a rebuke to the excessively woke. I mean, Republicans gained ground in the House in 2020. You saw Glenn Youngkin win in 2021. I think that my personal opinion is that the race of Trump versus Biden was a repudiation of Trump, but not necessarily of conservatism. And I think we're going to see a good election again in 2022 because this wokeness stuff is going too far. It is a small minority of people who are pushing a radical agenda that has really deleterious effects. And don't give up, fight back. That's my message to leave with.
Well, Tevi, Addie led you to a better conclusion than I was going to. So thank you, Addie, for doing that. Tevi,
well, she's a member of the Troy fan club. So.
Absolutely, right. How can folks follow your work? What's the best way for them to do that?
Well, the two things I would suggest are you follow me at Twitter at Tevi Troy, at TEVITROY, and then you can sign up at my mailing list, tevitroy.org, tevitroy.org, and you get all my articles when they appear.
Thanks so much, Tevi.
I know this is not efficient, but I have to say Tevi is prevalent on many podcasts. So if you're a podcast listener, Tevi, can you plug that? Because I read the article the old-fashioned way, but I mean, I think it was really effective on different venues. So if you don't mind.
Yeah, no, I just did Matt Lewis in the News, is one of my favorite podcasts. I did it on a recent Wall Street Journal piece I did. I did the commentary podcast on the commentary article. I also appeared on Jonah Goldberg's The Remnant, which I know Addie listens to. And I'm a gold jacket wearer of The Remnant, having been on 5 times, which is what he says. If you do 5 times, you get a gold jacket. Mine hasn't come in the mail, but I've told him my size. And I'm a huge fan of podcasts. I listen all the time, but I also participate and go on them as well. And I think they're just a great medium. I mean, to the extent that we have this media filter that limits what you can hear, podcasts allow you to get past the media filter and hear the voices that not just that you want to hear, because I listen to both left and right, but the voices that are telling you what's really going on, as opposed to what the certain sanctioned medias want you to hear.
Yeah, podcasts are becoming the real sort of alternative to traditional and compromised mainstream media.
Right. So, and Twitter and Facebook can't control them.
For me. I mean, I read Tevi's article and I listened to the podcast, but of course, as we know, I'm a Tevi fan, but it was, it's different to listen to it. So I would sort of endorse to anyone that doesn't do podcasts or is uncomfortable with them to seek out the commentary podcast where Tevi Troy is the main guest, because it was very fulfilling. So
thank you. I appreciate it.
Very good. Tevi, thanks so much for joining us, and thank you for the work that you do. We hope to have you back in the future on Zoom events, and we hope to get you to Dallas in person at some point.
I'd love to. As you know, I got my PhD at UT. I love Texas.
Yeah.
I haven't been there in a while, but post-corona, I'd love to be there.
We'll get you down here. We'll put a 10-gallon hat on your head, and we'll get you in front of a live audience. How about that?
Amen. Thank you so much.
All right. And thank you so much to all of you who joined us today. Thanks for joining us. Again, thank you for those of you who are IPI supporters who make this possible. If you like this content and you're not a supporter, talk to Addie Crimmins. Her email address is Addie, ADDIE, at IPI.org. She'd be delighted to talk to you. Thanks so much for joining us. We wish you a good rest of your day. This is the second to last Zoom event we will be doing this year. We'll be doing one more on December 10th on an intellectual property topic. But for those of you who are only interested in healthcare, we will wish you a happy holidays, and we will see you next year. Tevi, thanks so much for joining us.
Thank you, Tevi.
Thank you so much.
And thank you to everyone out there in the audience for joining us. Have a great day.